Our room has a presentation entitled Response Following Violent Incidents. Violence in healthcare continues to increase in frequency and severity. It is well documented that healthcare staff who experience violence have negative physical and psychological effects. The implementation of this project hopes to answer the following clinical question. Does the implementation of a standardized response plan checklist for physical assault or battery following a physically violent incident improve healthcare workers' perception of support from leadership and peers? The graduate doctor of nursing practice student presenting today is Annah Roper. Advisor is Dr. Diane Forseth, and also in community partner Wendy Moore. And I will go ahead and stop sharing and turn over to Annah.
So welcome, guys. So thanks for the introduction. Like she said, the title of my project is Response Following Violent Incidents. And she kind of already went over the background, but experiencing violence does have negative physical and psychological effects. Implementation of a standardized response checklist following a physically violent incident may impact the staff's sense of support from leadership, peers, and the institution they're employed at. So going through a little bit of the literature that supported this project, there's a need for support from peers, leadership, and the institution for nurses following patient violence. Needs include formal crisis intervention, which is debriefing, counseling, or a staff victim support group, an informal support, peer support system, and staff training. The Joint Commission guideline requires better tracking of violence, providing proper support when employees are victims of violence, training, and incident reduction strategies. And then in the clinical guideline put in place by the National Institute for Health and Care Excellence, has 5 objectives for managing violent patient incidents and includes identifying warning signs and triggers, preventing violent behaviors with de-escalation techniques, monitoring physical health during and after manual and chemical restraint, and immediate post-incident debriefing. So the project site or community partner and the reason for change was a large Midwestern tertiary healthcare center. And the unit of focus was a 10-bed locked unit that was created with safety at the forefront. So this includes having locked up equipment, vital signs monitors, computers, television, anything that the patient could use to harm themselves or staff is locked away for safekeeping. It also included the elimination of ligature points. For those of you who don't know what that is points where a person could use to hang themselves from, so to prevent patient harm to themselves. And then also a large lounge for patients to congregate and socialize with each other and with staff. Additionally, the nurses' station is locked and surrounded by a tall counter with thick glass so that there's a barrier between staff and patient should that be necessary. All the staff on this unit receive specialized training annually to prevent violent situations and safely handle these situations when they do occur. The patients that this unit serves are both inpatient medical surgical patients and emergency department patients who are at risk for violent and disruptive behaviors. Staff identified after about 2 years of operation that they were not receiving the same level of support following violent incidents between colleagues. There were incidences that some people received very extensive and in-depth support for perhaps the same violent incident occurring on someone else who did not receive that same level of care. This caused maybe some attrition. At that point, the staff had the opportunity to discuss concerns before they left for their next job. And that's when those themes came up, and a lack of knowledge and utilization of the resources available was also a concern. So this project kind of emerged during that time to help increase staff perception of support. So the DMAIC model was used to guide this quality improvement project. And that's the model that's supported by the institution. So it starts with define, measure, analyze, improve, and control. So you're defining the problem, you're measuring relevant data, and then you're going to analyze data after you implement the project. And from that data, you'll hopefully improve what needs to be improved so that you can control your project in the end. So something that's sustainable over time. The intervention that was created after the nurses identified the need for more support was a checklist. This had the resources available to staff through the institution. Some things that were available on the checklist, which you'll see in the next slide, were management, follow-up, and counseling services, as well as listing the various reports that the staff was expected to file after a violent incident occurred, just so that at that immediate moment after an emotional or traumatizing event like patient violence occurs, they could have something to turn to kind of help them through what needed to happen next. And so this checklist aligned with the institution's initiatives to create an awareness of the resources for all staff who fall victims to violence. And many stakeholders were involved in the creation of this checklist, including chaplain services, nursing staff, care assistants, security providers, and the unit management. And then as far as helping to carry out the quality improvement project, it was primarily the unit manager, nurse educator, and the charge nurses on the unit. So here's just the checklist briefly. And you can kind of see it's very simple, very basic, and you can go down, check off things as you're doing them, and then identify what support you think you're going to need afterwards. And that can be something that changes over time as well. So from the data gathered from the stakeholder input meetings and from interviews with staff that were leaving, we came up with the checklist intervention, and then following that, we created an evaluation plan. So an anonymous online pre-survey kind of began the process, and identified how staff felt their current support level after experiencing a physically violent incident before the checklist was. And it was broken down into peers, leadership, and the institution. And they ranked their perception of support from each entity on a Likert scale from 1 to 5, from very unsupported to very supportive. Additionally, in that pre-survey, demographic data was gathered, including gender, age, and nursing experience, so that trends could be analyzed. Following the pre-survey, the charge nurses on the unit received education regarding the checklist. And this included education using the teach-back method to show how to properly utilize it, and also to how to lead that short debriefing that should occur after staff experience violence. They kind of took the lead on that, and then individually, if there was multiple nurses involved in an incident, they would pull each nurse aside and help them go over all the reports that need to be filed if they had any questions on that. And then they would let the staff then fill out what support they identified that they needed following that incident. After it was completed, the charge nurse returned the checklist to the manager's mailbox for follow-up. Names weren't put on the surveys that were turned in because the manager had kind of access to pinpoint who needed what based on the reports that were filed. And then the charge nurse sent an email with any additional information that management might need to support follow-up and create additional awareness for the situation that occurred. And then the checklist remained active for 6 weeks, and then a post-intervention survey was sent to the nursing staff. The survey repeated the questions on demographic information and the support utilized in the pre-survey. Additional questions were created, and some of them were in a yes/no format, including whether or not the staff utilized the checklist, whether it impacted feelings of support or not, and whether or not the staff utilized peer support, because the literature showed that that was something that was very important and often not tracked. So trying to do our best to see if that was something that was utilized. In addition, it was asked that the people who completed the survey select which resources were the most helpful. And then an open-ended option also allowed staff to list any other resources that were not available but may have been identified as helpful. Due to kind of this COVID business that we're all experiencing right now, it was also decided that to get better data about what can be done to help support people post-violence, that some brief interviews were conducted, and they consisted of 3 open-ended questions about what went well on utilizing the checklist, what other resources are needed, and any other general comments about the checklist or support needs. They lasted an average of 7 minutes and were audio recorded and transcribed, and then theme analysis occurred. So some of the results, overall themes learned from the survey included that staff felt supported by their leadership and peers, but less so by the institution at baseline. After the intervention, the staff support sense from peers and leadership remained about the same, but the support that they felt from the institution actually increased. And then overall themes learned from the interviews included that the staff viewed the checklist as a valuable central resource to turn to after an emotional or traumatizing event like violence. And they stated that they also appreciated the awareness that they gained from having a resource listing support options available through the employer. They identified during the interviews that one of the most helpful resources that they used was their peers, because the peers understand what goes on the unit, the violent acts that occur up there, and how we kind of cope with them on our own outside. And it was identified that it was nice to have that. And without that, that they might not still be working there. Some resources that were not available on the checklist that were identified that they might be helpful were things like an anonymous tip line. And this was described to me during the interview as like the suicide hotline, like an anonymous line that you can call 24 hours a day. They maybe won't understand kind of what happened or what support options you might need, but it would be a way to get what you had on your mind out, and maybe not necessarily something you wanted to burden your family with. Additionally, they said that chaplain services they utilized, and it wasn't on the checklist. Then there was some touch points on education. So comprehensive education on the legal processes and what happens if you choose to file charges based on patient violence. What does that look like? What does it look like when you get subpoenaed? Those resources were described to be lacking in the interviews. In addition, this was mainly a medical floor, so they felt that there was some gaps in psychiatric comorbid conditions in addition to the medical conditions that we see on the floor. And how does violence prevention and psychiatric diagnoses go together? The final theme kind of is that the tool was used kind of inconsistently. It would depend on the charge nurse who's running the debrief and the discussions on support, and that it wasn't always completed. So it'd be more effective if it was used in a more mandatory way. And the staff also felt that if it was mandatory, it would be a bit more sustainable. Some limitations, it's a quality improvement project, so it only occurred on 1 unit and had a small sample size, just due to the nature of a quality improvement project. However, this data does provide some pilot data for a larger work group in the institution who focuses on violence. So also you can see the importance sometimes of quality improvement projects. Furthermore, the checklist utilization occurred only when there was a physical assault on staff members, and after this was completed during the interviews, the staff felt that the checklist could also be expanded for use in different situations that would warrant physical or chemical restraint. So things like terroristic threats, significant damage to property, and threats of harm towards staff. And then finally, the last limitation was that I, as the principal investigator, was employed on this unit. So there's bias that I introduce into this from that. Kind of lessons learned. Nursing found valuable in having the list of resources readily available and to just see like all the supportive options that the institution was providing for them. This was successful in the inpatient setting that it occurred on and has potential to be successful in other settings as well. All right, so checklist kind of helps inform staff, management, and institutional leaders of support options to meet the needs of nurses who are victims of violence in a more expedited and comprehensive manner. Staff perception of support may also affect choices to leave a position, and therefore quality improvements like this one may address the support concerns and help with attrition and job satisfaction. So in conclusion, this project demonstrated that implementing a standardized checklist and response plan following a violent incident can improve staff's sense of support. And it also has the potential to be more beneficial if it occurs consistently, and continuous evaluation should continue to ensure that it's meeting the needs of violence victims. Each individual is unique and requires different interventions. And as violence increases in frequency and severity, so should our efforts to curb its effect on staff. So I'll take any questions. There's my references for you all to see, but the question is, do you plan to disseminate the information from this project to organizational leadership, especially in regards to the resources employees felt were lacking following instances of violence? And the answer is yes. I'm actually on the larger work group as well, that this pilot information is going to inform them. They're working heavily, even through all this COVID stuff, to make sure that staff is feeling supported during the time. So yes, I have a meeting, I think, at the very beginning of May to discuss